Welcome to our educational video. This video has been developed by MedNav. MedNav is an organisation that helps to promote women's and children's health worldwide through education and innovation. If you'd like to know more about our work or indeed support us, please visit this website link.
First-degree tears may heal spontaneously, but will need to be sutured if they are bleeding. For second-degree tears, clean the area in order for you to clearly identify the perineal anatomy and infiltrate with local anaesthetic. Identify the apex of the tear. This can be helped by inserting a swab or a tampon into the vagina to remove the excess blood. It is important that you remove this at the end of the procedure. Place and secure the first suture 5 mm above the apex to secure any vessels that may have contracted above the tear. Repair the posterior vaginal wall with a loose, continuous, non-locking suture from the apex to the fourchette or hymenal remnants. Insert the needle back through the skin at the fourchette and then back through the vaginal mucosa to exit in the centre of the perineal muscle tear. Approximate the perineal muscles, the bulbal spongiosus and the transverse perineal muscles using a continuous, non-locking suture. Depending on how deep the tear is, 2 layers of sutures may be required. By this point, hemostasis should have been achieved. Bring the suture out at the apex of the skin and close the skin using subcuticular sutures. Use a loop or Aberdeen knot at the posterior fourchette to finish the procedure. Subcuticular sutures associated with less pain than sutures that penetrate the skin. Remember not to use any undue tension, as this can result in chronic pain. Finish off the procedure by counting your swabs and equipment and carrying out a vaginal and rectal exam to ensure adequacy of the repair and that no suture is palpable in the rectum.